Hi everyone, it's been another decade meeting you guys, and I'm so happy to catch up with my viewers. I'm sure my views are not reaching multiple people, but then that goal will always be there in my mind. Like I said in my previous video, I was doing a rotation in New Jersey and then I got to know I did not match. It was a shock, trust me. The feeling is really, really bad. I'm still coping up, settling in, wanting to explore more. But then I wanted to make this video exclusively for someone out there reaching out to the rotations and what I learned in the rotations is what I'm going to speak about. It will have all the um, concepts related to family medicine and somewhere with the internal medicine. It's going to be a quick video, and I will talk to you about all those things I learned in this rotation. Firstly, I went in without anything like a idea whatsoever. I just went in. After that, slowly I tried to catch up with the patients I was allotted. I did new patients and I also did old patients. I was asked to jot down the history taking, especially HPI. So I did see a lot of videos. There are so many helpful videos out there. Just type HPI on the chat GPT and you will find loads and lots of things. So roughly what I would say is, like there are like four components. In the HPI, you're going to talk about soap. That is the subjective, what the patient complains exactly. Those words are going to be uh, jotted down as it is. And then objective, where you will see what the findings are. You will pick on if the blood pressure is high, low, or normal, vitals, and your physical exam goes into the objective one. Finally, it is the assessment where you will come down with the differential diagnosis and followed by a particular plan according to what the patient has. So that ends up with the soap. But then I was particularly focused on HPI. And there is this really cool mnemonic which I jotted down here. It says old cards. Okay. So old cards is a pretty nice mnemonic to remember, where you are looking for onset, location, duration, character, aggravating factors, and what the patient has, like a treatment, if the patient has been on any supplements. So all of that old cards, I can write it down in the comments, or you can also Google it. This is a pretty simple and pretty easy. After which you will do the past medical history. And that once this is done, you will do the social history, what the patient uh, is up to. And then you will do the family history, which is also a part of this. Finally, if it's infectious, you can do travel history, immunization history for kids. And yeah, that is it. So I was presenting these cases. It was a very learning experience. In fact, this rotation was more like I was going towards better aspects. And I think choosing a rotation really plays well in your favor if you have it way ahead. like not the last, but in the first rotation, if you have a good experience, that will kind of prepare you for the rest of your rotations, even if when the rotations are not well designed, because then you can pick on what aspects are really good and what are not good. But then if you start on a rotation that is not very good, meaning the preceptor doesn't really allow you much, and it's not hands on, um, then you may want to figure out yourself to show that you are really active. So that actually creates a friction on some aspects, because you don't know what and where to start from. So every time, if you're rotating for the first time in your application, make sure you pick a right rotation, a rotation where a feedback is given to you, and a rotation where you are actually learning, in getting involved with the colleagues around you and interacting actively with everyone around. So this one has been a very great rotation, but I had it all the way to the last of my rotations, what I did earlier. So this is something like a takeaway I'm giving you guys, and I'm sure it will be of help to someone out there. So next one is, we talked about how in diabetes the HbA1c is normal, and what do we do if the HbA1c is normal? Any guesses? I don't know. I'm not having any one-to-one interaction, so I'm just going to tell what I remember, and this is for my remembering purposes as well, because I did not want to limit it to books. I wanted to spread what I learned. So there was this question where a patient has diabetes, and um, he was recently diagnosed with the diabetes, but his HbA1c remains normal. So what do we do? Do we discontinue the medications, and uh, what or what do we do? So the further action in this patient is, we will educate, we will encourage his diet and exercise. Firstly, it's the lifestyle changes. Then, if the HbA1c on the next visit is getting worse, we will need to start them on the medications. Once a diabetic will always remain a diabetic, regardless of what his HbA1c has been like. Okay, so this is one important point I learned from my preceptor. And then there was a situation where every time I was asked on the statins. So you need to know what the high dose statins are and the low dose statins. High dose statins include atorvastatin and rosuvastatin. Atorvastatin 40 80 mg, rosuvastatin 20 and 40 mg. I can't tell you how much this was being emphasized every time. So, yes, statins are very important. The next question we run into is, when do we use statins, and who are the candidates who should be on the statins? There is revised editions, new chart on the use of statins. Of course, when there is hyperlipidemia, we do statins. And if there is cardiovascular diseases, we do statins. Other than that, most importantly, we do statins in patients with diabetes, in patients who are at risk for stroke, and in patients who have peripheral arterial disease. Um, so these patients do need statins. Sometimes you need to explain and go beyond. You just can't simply prescribe statins, because patients will reach up to you to ask why are they being on the extra drug. What is the need? In that case, you may want to explain in detail about what the statin does. So what just explaining roughly to about this concept I learned from my preceptor. So the statins are like the lipid lowering drugs. We cannot simply say that out. We got to explain this with the appropriate examples such that the patient is on the same page and understands the importance of taking this kind of drug. So, statins are basically a pill that helps the blood flow to be normal, meaning in a patient who has high lipid levels, the clot or the fat can stick into the capillaries, into the blood vessels, hampering the blood flow. And so there could be a stasis, stagnation of the flow, resulting in the clot formation. So it is very dangerous. It prevents the clot from moving all across the other organs, meaning the statins are going to stabilize the clot. Not just this, studies reveal that statins are also associated with inflammation within the arteries. In any situation, either you have the inflamed vessels or you could have the clot. This clot cannot just remain in the blood. It can make its way to the brain, resulting in stroke, or it can move all the way down to the extremities, resulting in some sort of pain. And pain is because there is no blood flow, adequate blood flow. So, statins is something that will prevent the clumping, and it will also uh, reduce the clot formation. It and most of the times it is important to have this, because um, there is a synergistic effect with the vessels. As we age, our vessels are going narrower, and it only gets blocked because the bloodstream is going to get narrowed naturally. But with the use of statins, it is going to lower down the inflammation inside the blood vessel, such that the blood flow is going on in a normal flow, and also um, it takes care of the clots. The clot, it cannot necessarily be a clot. It can also be a fat deposition, or it helps with cholesterol deposition. So there are so many things attached to it. So that should be convincing enough for the patients. You need to go beyond and broad. You can also Google it on the Open Evidence website, where they tell you in detail about when to use statins. Next up, we talked about GFR rate. Okay, so in patients who have kidney injuries, most of the times, in the previous studies, we learned losartan is the very first drug of choice for proteinuria, to reduce proteinuria. But it is not. It turns out there are several other drugs that are actually way better than losartan. We got to keep up reading um, the research work that was being done. So, catching up with every aspect is also one of the crucial activity to be done as a doctor. So, losartan is no longer there. It is SGLT2, enfloglostocin, SGLT2, you can remember, and something what we call as flen, that is flenadenone. This is said to be superior to losartan in patients with CKD, especially in terms of reducing that GFR and having that extra protection to the kidneys. All right. Um, One of the most important point I forgot to mention on the use of statins is you always have to give it in patients with diabetes. Regardless of what the LDL levels are like, you go to give statins in diabetic patients because they are at risk for several complications. Again, talking about the complications in diabetes, we have the microvascular complications, the macrovascular complications. So, which is the one that is being hit very hard? It's the order you can remember. It is the microvascular complications like retinopathy, nephropathy, and neuropathy. So, first it's the eyes. That's why we always have to refer the patients to ophthalmology for cataract evaluation. And then, let's say a patient has a normal HbA1c but has had diabetes since a long period of time. What is the complication he is still at risk for? Yes, I think some of them must have got the answer. It is the macrovascular complications. Regardless of what the HbA1c has been like, they are at risk for cardiovascular diseases. And so, statins are extremely helpful and mandatory for patients with diabetes. All right. Next, you got to remember the gold standard drugs for cardiovascular diseases. So one is ERBs. Next is beta blockers, and spironolactone, sacubitril, and SGLT2 inhibitors. Next up here, what do I have? What do I have? Yes, so we talked about brain natriuretic peptides. This there is something like neprilysin. Neprilysin breaks down the PNP, and this is a drug that is given for the cardiovascular disease. You can Google it further. I'm not sure exactly about it. Okay, so what are the conditions where you will see falsely elevated BNP is neprilysin. This is one. Next, in case of obesity, adipose tissue reduces uh, less amount, some enzyme that degrades the brain natriuretic peptide. So these guys are going to have a low BNP level. Okay. And so the hormone clearance is pretty higher because the adipose tissue that is deposited in a bulk in obese individuals has got these receptors loaded well enough to receive this hormone. And so there is no risk of reaching the threshold or no risk of saturation. The receptors are adequate enough, they take up the hormone, and the hormone is just being metabolized in their body. So just remember, for obesity, the BMP level is going to be low. Next, up here is we talked about abdominal aortic aneurysms. So, abdominal aortic aneurysms is um, is something where we screen for aneurysms, and we start screening after age 65 onwards. So he would always stress upon the fact that it is only done in the males. Do not say it's done in the females. I know it seems such a simple and straightforward point, but then that's important. Um, so if someone tricks you by saying women, X, she smoked so and so cigarettes and has been significant in their smoking history, do you screen for abdominal aortic aneurysm? Don't fall into this trap and temptation of saying yes, because a screening only and only happens in the males. Okay, just get that straight in your head. And who has ever smoked, right? So that is like the basic words that are being framed in the you world. So how if a person smokes like a 5 cigarettes, and would you screen for AAA in that patient? No, 5 is less, right? So at least they have to have around 100 uh, cigarettes in the past history over a 5 pack years. Okay, so this is it. This is very important. Next, we talked about infections. Yes, it was a clinic where we were seeing family members and also young, old, everyone. So mostly cases I saw were more towards common cold and cough, as that time there was a blizzard happening. So um, the you need to remember the viral infections as to when it turns to the bacterial. So viral is more likely going to be simple. There will be no exudates, and the duration is less. But in case of bacterial, initially they will have better response, and then slowly after 2 days they will feel exact opposite to what they were feeling, meaning it worsens. And if they have associated high grade fever, and if at all the symptoms last for over 10 days, that means they are going to have antibiotic pill likely in that situation. So you need to know these things. And next one is I was asked on how do we treat hyperkalemia. This is also important. Hyperkalemia. Yes. So if there are cardiac changes, we do the calcium gluconate that is responsible to stabilize the cardiac membrane. And Kieselate is given way to last. Do not say that. Okay. And of course, beta agonist will activate that sodium potassium pump, and thereby lower down the potassium levels. um, Finally, you can give insulin And this is one of the treatments for the TKA. We want to hold insulin if the potassium is less than 5.5. Okay, so what this does is it will push away the extra potassium inside the cell, so leading to hypokalemia. Know the treatment for the TKA, how to um, have the patient shift from the ICU to the ward. When do we make a transition from the IV insulin to the subcutaneous insulin? And what is that we monitor to basically know if the patient is having a severe DKA or what? So yes, it is anion gap. If the anion gap is wide, then it is pretty severe. We got to be on toes and try to get the patient on the IV saline infusion, because the patient is must be mostly dehydrated due to lot of peeing and also vomiting and so forth. So we want to get that gap a bit closer. That should be our main aim on how we will be discharging the patient. Next, if it gets better, then yeah, you can switch the patient to the subcutaneous route. But then, if you are doing so, make sure you are also precautious on the timings. Subcutaneous one takes a bit of time to kick in. Okay, by during those time, we want to keep a check on the CMP levels and also on the sugars. So one of these points that brings me to what the DKA has been like. So there are several precipitating factors before one goes into full-fledged DKA. Most importantly, it could be pneumonias, okay? Any respiratory infections in the past. So, next one we talked about TB. TB, I know this is more like a burning issue in IMG, IMGs, and also in people who are migrating from the developing countries. TB is pretty common. So, but then we want to note when we want to start the treatment and who are the guys who would need the treatment on mandatory basis and so forth. So we discussed a lot of things. I think TB is something that's pretty easily tested, and also it's not very dry topic. But then we had discussed about the passive TB. What is like, for example, if a patient walks in and you get to know he has passive TB, uh, would you treat these patients or no? What's the question? So the answer to that question is like you will still go ahead and treat these patients. Why? Because there is 1% chance out of the 10 people, one person is likely to develop active TB. So the studies, the research has revealed this, and so you treat the patients to be on the safe side. But then it also depends on how the patient is reacting to the treatment, as to if he is receptive, if he is concerned. So most of the times, I think in the world they say that if you are in the healthcare settings, you will need the treatment for it. Hmm. So next point up here is I have a patient with the TB, and we did a sputum acid fast strain. Um, it came out positive. That means the patient has active TB. So you just get him to the negative pressure ventilation isolation room. Okay, start the treatment right away. Okay, and yeah, you have to confirm it with not just the X-ray, but you will also go ahead and do sputum acid fast stain. Okay, if that's positive, you diagnose it as one having active TB. Now, there are people back in the home countries who have had BCG vaccines, especially in India. So, if they have had this, the skin test is likely going to turn out positive, and they may be labeled as passive TB. But no, it's not. The picture is different. If they have had the BCG vaccination, the skin test is falsely positive. Um, and so you can't do you can't label them as having visit TB. We have to go ahead and do the blood test. Only then it is going to become more towards specific uh, TB, passive TB or active TB. But then chest X-ray is also the determining factor there. Now, what is the treatment? Treatment was explained so well, and let me tell you, it's like 4 for 2, okay, and 2 for 4. It's that simple, just that simple. So 4 for 2 is right? So rifampin, isoniazid, pyrazinamide, and ethambutol. 4 for 2, meaning you're going to give 4 of these drugs for 2 months. And then you have 2 for 4. That is going to be isoniazid and rifampin for 4 months. Okay. All right. Moving on. I have got mm, I have got here about subclinical hypothyroidism. So there were so many patients presenting to us with subclinical hypothyroidism. Do you know what the picture is like? You need to know this. Subclinical hypothyroidism. What does the TSH look like? What does the T4, T3 look like? So if it's hypo, remember TSH is going to be high. And T3, T4 is going to be normal, absolutely normal. Do you treat these patients? No, because there are no symptoms. Okay. But yes, if the TSH is over 10, then yeah, maybe you may consider treatment. Okay. Next, what is resistant hypertension? This is one of the um like the topics I'm discussing are pretty high yield, especially whenever you go into rotations. You will see this day in and day out. It's pretty common, like the bread and jam of the entire um, specialty, I would say. So get used to these terms and also the concepts. Um, and you can just be there like this, that will be plus an add-on to your performances at the rotations. Okay, so moving on to the topic, we have your resistant hypertension. What is it? It is, we give them 3 drugs, anti blood pressure pills. Okay, so even after 3 drugs, the patient has a high BP. That means it's resistant. And one of those has to be thiazides, hydrochlorothiazides. Okay. And then I was asked on asymptomatic bacteriuria. What is that? It is a situation where the lab results are um, are showing 10-5K, 10-5 organisms, but the leukocyte esterase is negative, nitrate negative, okay, and the urine pH is also kind of normal. That means the patient has asymptomatic bacteriuria. There are bacteria in the urine, but the test results show nitrate negative, leukocyte nitrate, both are negative. So, do you treat these patients? This was a question. Of course, you do, unless a patient is not pregnant. Yes. So I'll put it the other way around. If the patient is pregnant and has asymptomatic bacteriuria, you will treat the patient because there is increased risk for a preterm delivery due to infections in the mom. So we take care of all the infections, especially in the first trimester and also in the third trimester likely. Anywhere across, it increases the risk for preterm birth. So that is one thing. But other than that, you need to remember asymptomatic bacteriuria is treated if the patient has invasive urological procedures, um, renal transplant, and short-term indwelling catheters. So these were the three indications. Okay. Mm, yes. So next one. Oh, I don't really have much. I think yes. Hmm. Not much, not really. That wraps up my session for today. And I hope you like this session. And if you do, uh, help your friends, help your colleagues, let them know about what I spoke to you. Let them get the same experience as you. I mean, we are all in the same pool, but then, I came across people who barely share things. I find it so strange. We, being in the same field, being being in something where we are all heading to a common goal, rarely share things. So it's always important. You don't need to bring up like you know everything, but you can always give a clue to your fellow mates. So I'm just asking you to forward this video to anyone in your community and let them know. Let them be better in their rotations as well. Okay. And that's all I have for you guys today. I hope it's been useful. I pray everyone gets matched. Um, lately, I have heard people saying everyone gets matched, everyone has their place. And there are people encouraging me and telling me that if it was easy, everyone wouldn't have gone into the match process. So there are so many people giving so many hopes. So it's just that we need to pick on the positive aspects, what your mind really tells you and how your heart guides you to what your mind says. Make that juggle between your mind and heart, and then know what you are chasing for. Make a decision by yourself, most importantly. Okay. All right. I think I talked a lot today. I hope this video turns out to be a good one, a better one, compared to the last videos I've been posting. And it's you guys who have made my previous posts better each time I post it. So thank you for that. And I hope to do more. Keep up with this journey, uplift everyone around you. Bye for now.